Good afternoon. Thank you for joining the We Can Education series. Today's presentation is titled Holding Up the Mirror, Creating a Trauma-Informed Approach. Our presenter is Dr. Kelly Hodges. Dr. Hodges is a pediatrician at the Milwaukee Child Advocacy Center and medical director for the Care for Kids Foster Care Medical Home Program. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. If you are viewing with a group, make sure to send those names and email addresses of all attendees to Kathy Artolini. To ask a question during the presentation, you can use the question pane on the control panel. These will be addressed at scheduled breaks. In order to obtain continuing education credits for today's session, you must register online and complete an evaluation within 10 days. You will be able to access the evaluation immediately following today's webinar. For a list of future topics, please visit our website, wichildabusenetwork.org. Now we'll proceed with today's presentation.
Okay, thank you, Sarah. Good afternoon to everybody. As Sarah mentioned, my name is Kelly Hodges, and I'm a pediatrician with a section of child advocacy here in Milwaukee. And today I'm going to be talking about strategies for creating a trauma-informed approach. And obviously my lens is coming from a healthcare provider as a pediatrician who sees children who've experienced quite a bit of trauma in their lives. But I'm hoping that the approaches and the examples that I give can be applied more broadly to whatever field that you on the call are working in, whether it be child welfare or law enforcement or schools or really any other setting that works with traumatized children and families. How to really take into account their past histories and past traumas and provide the best possible care for children and families. So as Sarah mentioned, please type in any questions that may come up along the way, and I will be happy to try and answer them. So, I'm not advancing. Just one second. Okay, there we go. So I have no financial relationships to disclose. And our objectives for today is first to briefly review the science of toxic stress and the ACE study. I'm sure many of you are familiar with this work, and so I don't want to spend too much time going over that, but just sort of as a level setting, we're going to review that briefly. Then talking about why a trauma-informed approach is important when interacting with children and families, and also to learn some practical implementation strategies for trauma-informed care in whatever setting that you're currently working in. So first, what is toxic stress? So it's really important to keep in mind that adversity and traumatic events are not necessarily toxic for a particular child. Healthy development includes coping with adversity, and facing adversity is a normal part of child development. However, the process of normal development can be derailed if the stress response is prolonged or if a particular child's resiliency factors are low. So toxic stress really is the strong, frequent, or chronic adversity that exceeds a person's ability to cope with it. So really kind of the wear and tear effect of adversity over time. So to think about this as a few examples. So a positive stress response that is good for building resiliency and character might be the first day of school for a child, or having to do a class assignment that requires speaking in front of the class. So, you know, that would evoke some nerves and some jitters, which is just a part of normal growth and development. A tolerable stress response could be something more serious, like facing a natural disaster or the death of a grandparent or a family member. So a little bit higher level of stress for a child, but assuming they're involved with some stable and nurturing caregivers who can provide them resiliency, that's something that they should be able to adapt well to. And then there's the more toxic stress response, so something that's really ongoing. So for example, a child who's growing up with a mother who has severe mental health problems and really can't care for that child well, or a child who's having ongoing sexual abuse over years of time. Those are stress responses that would be very difficult for a child to handle and would become more of a toxic situation. So then what is trauma? If adverse childhood experiences don't necessarily equal trauma. And that was really the point of the previous slide, that a single episode of even a terrible situation or an episode of abuse that's followed by believing, protective caregivers who make the child feel safe and nurtured, those experiences may have minimal to no effect on the neurodevelopment of a child. So really how we as caregivers, as professionals involved in the lives of children, how we interact with children and their families really does matter. And this is the resilience that we're trying to build in children, which is the strength that helps each and every one of us deal with adversity when it comes up in our lives. So this is a schematic that I include just because we do know the science shows us that persistent and toxic stress can actually change the brain architecture of a developing child. So that top schematic is representing a neuron and the normal neuronal connections that develop in a child's brain. So the typical brain has many, many neurons, and you want the neurons to connect with each other and talk to each other for normal brain development. So up the top picture represents normal brain development. The one on the bottom, you can tell there's just less connections and less interactions between the neurons. And that is representing a child who's undergone traumatic stress. The child is so busy worrying about their fight or flight mechanisms and responding to toxic environments that they don't have the capacity for their brain to develop the normal architecture that we would expect in a child that age. So really, there's quite a bit of science behind this, that this type of toxic adversity and chronic stress really does change a child's brain architecture. And again, that's why resilience is so important. Safe, stable, nurturing caregivers, environments can help to preserve those neuronal connections. And everyone who interacts with a child has an opportunity to promote resiliency and really make sure that the children who have experienced adversity get the best possible outcome that they can. This is a visual depiction that I really like to include in these types of talks that was put out by the Fostering Futures Initiative. So some of you may be familiar with Fostering Futures. It's an initiative that's sort of under our First Lady of the state, so Mrs. Walker, who really has taken on this initiative to try to promote trauma-informed care and spread the message of early adversity and toxic stress throughout the state of Wisconsin. And this schematic is of a little girl, and on her forehead is a meter that shows really that her things can go in two directions, either to help heal or to help harm. And it states that every interaction causes a reaction. So whether you interact with a child one time on a daily basis, whether it's your own child, every time you interact with that child, you have the opportunity to make those interactions either positive and help heal what's happened, or harmful and make things worse. So I really like to keep this schematic in mind when I'm in a room or examining a child who's experienced stress. This is a schematic that really just hits home for me. So again, I know many of you are very familiar with the ACE study, but just to put this up here for those who may be not as familiar, the Adverse Childhood Experience, or ACE study, was a study that came out in the mid-90s out of Kaiser Permanente Health System in California, and also in conjunction with the Center for Disease Control. And really what they looked at was these factors of household dysfunction, abuse, and neglect, and they asked adults to reflect upon their childhood and to answer this questionnaire about how often they had these experiences. And what they found was that it was a much higher percentage of people than first anticipated who had experienced early childhood adversity. So you can see the numbers there under Kaiser, which are the numbers from the original study. And then This study has been replicated many, many times by many different subgroups, and Wisconsin has undertaken its own ACE study through the Wisconsin Children's Trust Fund. And those are the results of the most recent outcomes, which were from 2011 to 2013 data. So you can see that these are very prevalent in Wisconsin as well, similar to the original study in California, and that many adults, when reflecting back on their childhood, report that they had experienced these types of adversities. And the ACE study goes on to talk about how this early adversity relates to poor health outcomes in adulthood. So this is another graph that's taken from the Wisconsin-specific study, looking at of the people who answered the questionnaire, how many people had 0 all the way up to 4 or more ACEs. So you can see from this, the red piece of the pie is people who reported having no ACEs in childhood. So 58% of the people who were surveyed reported having 1 or more ACEs. So this is very, very common, and no matter what type of field you work in or no matter where in the state you live in, you will definitely be working with and encountering people who've had an ACE history, especially looking at that significant piece of the pie, the 14% who've experienced 4 or more ACEs in childhood. This picture of the state is breaking down the state by county and looking at the percentage of people in that county who had 4 or more ACEs. So the key is at the bottom. So the dark red color is showing that more than 20% of people in that county have experienced 4 or more ACEs. So where I work in Milwaukee County, you can see where one of the counties that has the highest prevalence of ACEs in the people we care for. And you can see throughout the state where you live and work what the percentages are for where you come from. But again, even if you're in a yellow county where the percentages may be lower, there's still going to be a lot of people there who've experienced ACEs and still a significant number who've experienced 4 or more. So this is probably a problem everywhere, no matter where you work. So I mentioned that a big part of the ACE study was linking these early adversities to health concerns and health problems in adulthood. So we're not going to go into every single thing because that's not the purpose of this lecture, but I just pulled out a few to kind of show you the correlation. So this is looking at adult rates of depression and correlating it with the number of ACEs. So you can see on the bottom, the 8% is people who report having 0 ACEs. Their rate of depression is around 8% versus going on up to those with 4 or more ACEs. The prevalence has increased up to 35%. So this is repeated over and over in many different disease processes and social determinants and high-risk behaviors. This one looks at 3 together, so health risk behaviors, so that's things like cigarette smoking or early initiation of sexual practices or IV drug use, things like that. The green bars are poor general health, and then the red are chronic health conditions. And all of those are higher in those with 4 or more ACEs than those with 0 ACEs. The list of ACE attributable problems that was put out in the original CDC article is listed here. And this was, like I mentioned, in the mid-90s. And since then, this list has really expanded. There is a lot of research going on all the time, and new things keep getting added to this list. So even in the last few years, things like hypertension and even some cancers have been tied back to this early adversity. So many, many health outcomes, many high-risk behaviors really feel the common linkage is back in early adversity. And this is another way pictorially to kind of say what I just talked about. This is looking at the population attributable risk for several health and health risk behaviors. So If you look, for example, at the suicide slice of this pie, the darker part in the middle that says ACEs, which we kind of refer to as the oil spill, takes up about 67% of the suicide piece of the pie. So what that is saying is that having a history of ACEs puts you at a risk for suicide. So of all the suicides, a history of ACEs is putting you at a much higher risk than if you wouldn't report that you had ACEs. So it's important to differentiate that this isn't a causative type of research. So it doesn't mean that if you've had early adversity, it causes suicide, but it does put you at a higher risk for these type of outcomes. So the original ACE study and all the subsequent studies that have been done do have some limitations, which are really important to acknowledge. The ACEs really are looking at exposure. So did something happen or not? They're also focused on things that happened in the home. So they're not taking into account things like neighborhood or community violence or safety issues or things that may have happened at school or elsewhere. So it's really focused on a child's experience at home. It's also, as I mentioned, a retrospective study, so they're asking adults to think back about their childhood, which anytime there's a retrospective type situation, there's always the opportunity for kind of recall bias or just not being able to kind of totally accurately remember what happened as childhood. So those are some limitations, as well as the ACE study does not look at frequency. So it's kind of a yes/no, did you experience physical abuse as a child? It doesn't take into account a one-time abuse versus something chronic that was happening day after day for years. Similarly, the intensity. It also doesn't talk about the timing. So there's a lot of science now that's looking at the timing of early adversity, and that it really does matter when some of these experiences occur. And really in those first 3 years when those neuronal connections that I talked about are being really made, and the brain is in its most critical time of development, that sometimes things happening at that time may have a bigger impact than happening, say, as a teenager. So this doesn't take into account the timing at all, which is another big factor. And again, as I mentioned, community or other events aren't taken into account with this. It's really just what's happening in the home. And the ACE study also doesn't take into account the resiliency effect of the child's environment. So were they having adversity but in a home with a resilient caregiver or a community support, or were they really facing these obstacles alone? So whenever we're talking about the ACE study, it's just really important to recognize that there are several limitations. All right, so now that we know and understand about ACEs and toxic stress, this is what we really want to understand. How can this help me as the provider provide the best possible care for children and families that I work with? And I think in order to do this, we first really must recognize what the signs and symptoms of trauma are in children, because often this isn't recognized by people who are designed to help them. And then once we can recognize that, we also have to understand how these behaviors are adaptive to the child's previous experiences. And this understanding will help us to provide the best possible care for these kids and their families. So the signs and symptoms of trauma are not always straightforward to recognize. These symptoms are not specific for trauma. So that means they may be due to trauma or they may be due to something else. So it's not a simple checkbox that if the child is doing X, Y, and Z, then we know they've been traumatized. Some of the symptoms can be things like difficulty concentrating or difficulty falling asleep or lack of energy or impulsivity. And we know those can masquerade as other issues as well. The symptoms may also be subtle, and especially for teenagers or adults, the patients might not want to talk about them. So they might not even be disclosing them to us as the people who are trying to help them. And also symptoms can vary by age in children. So what trauma symptoms look like in a 6-month-old isn't going to be the same as what it looks like in a 13-year-old. So when we talk about symptoms and recognizing them, in infants and toddlers, we're really looking about trouble with their self-regulation. So being very fussy or crying and sort of the inability to self-soothe or calm themselves. Sometimes it can manifest as poor feeding or with sleep problems. Also often with insecure attachments if there's been attachment troubles at home. So attaching inappropriately to strangers. So what that could be either very easily to strangers, more easily than you'd expect, or having a really hard time attaching to strangers. So it can go either way. And also sometimes a heightened separation anxiety. So again, these are not specific for trauma. There's many babies who feed poorly for other reasons, but it's something that should be kept in mind if you're dealing with young children who are exhibiting these symptoms. When you move into younger children, we're talking more about things like sleep difficulties or regression. So maybe a child that's potty trained suddenly slipping back into having accidents. Signs of anxiety, the continuation of problems with self-regulation, so trouble with temper tantrums or anger outbursts, difficulty in calming down, sometimes with speech problems as well. And for the school-age child, again, we continue with the same theme. A lot of self-regulation problems, either in impulsivity or inattention. And I want to just pause at this symptom for a while because in my clinic, seeing pretty much exclusively kids who are either in foster care or who are in my clinic because there's a concern for abuse or neglect, so many of these kids are diagnosed with ADHD, and they come to see me and they have a ADHD diagnosis. Sometimes they have 3 or 4 medications that they're taking to help deal with the ADHD, and most of the time the answer is those medications really aren't helping. And that's because these symptoms of trauma and early adversity are very much in overlap with the symptoms of ADHD. And these kids very, very quickly get that label, which is understandable if they're exhibiting the same behaviors, but oftentimes it's because no one's really getting to the root of what is causing these types of behaviors, and it's really the child's normal reaction to their history of trauma. So I always like to just kind of pause and talk a little bit more about that problem, because it really seems to be the one that ends up getting these kids labeled with diagnoses and put on medications that may or may not be helpful to them long term. The school-age child also can start developing some social problems. You see them getting into trouble at school. They also can have some loss of developmental achievements. Also some more somatization symptoms, so kind of vague complaints of headaches or stomach aches, causing them to miss out on activities or miss out on school. And those can be hard for healthcare professionals or others trying to sort out what of these complaints are kind of an actual cause that needs to be worked up and needs to make sure there's not something medically going on, and which of these are more a reaction to trauma. And sleep disturbances as well would go into this category. And then for teenagers, you sort of get this dichotomy of either the internalizing teens or the externalizing teens. And sometimes they'll cross over with both types of symptoms. But for the internalizing behaviors, you see the kind of quieter kids who have anxiety, depression, maybe some PTSD or social withdrawal, a lot of cutting, thoughts of self-harm, and sometimes even suicide ideation or suicide attempts. The ones with externalizing behaviors tend to come to attention more quickly. They're the ones acting out, getting suspended from school, having delinquency, oftentimes turning to drugs, alcohol, or tobacco for self-medication, taking risk-taking behaviors, or running away. And then when we get to adults, really pretty much any symptom one can think of could probably be tied back to a history of adversity. So many on this list and many more that come out as the research develops. So as someone who's in a helping profession, trying to assist these children and their families, it's really important to be able to recognize these. Often, even if we're concentrating on the child in the family, if the adults are having trouble dealing with their own past adversity, it's going to inhibit their ability to be the best possible parent that they can be for their child. So being able to recognize and help parents and adults in these relationships as well is really ultimately going to be very important for that kid to thrive and do well. So as I said, adverse childhood adversity is very prevalent in our communities, in our state, in our country, and we are all going to work with children and families who have experienced toxic stress at some point. Individuals will have different responses to these ACEs, so some may have these trauma symptoms that we just talked about, but others will be more subtle and it won't be able to pick up on them. So really it's important to view this as an area where you need to just practice universal precautions. So that's kind of a healthcare term of universal precautions, but the analogy is that ACEs and toxic stress is like a bloodborne disease. So if you're doing a blood draw on someone, you can't tell by looking at them if they have hepatitis C that you could possibly contract from their blood. So for every patient you draw blood on, you're going to be wearing your gloves and you're going to be careful not to do a needle stick. And the same is true for childhood adversity. You cannot tell by looking at someone if they have a history of trauma or toxic stress. So every child, every family, every adult that you interact with, you really need to assume that they have a history of adversity and treat them accordingly. So that's really the type of shift in mind frame that we're trying to get people to come to really practice this way with everyone, because you just really cannot tell who has a history of adversity and who doesn't. And that's what trauma-informed care really is. Trauma-informed care is the consideration of a child or an adult's past experiences during an encounter. And that's the mystery of it. It's not any more complicated than that. It's just keeping that in mind when you're dealing with a child. In healthcare, that's obviously providing medical care with an understanding of their previous experiences and how those previous experiences can shape that person's approach to their own health and to their ability to understand and comply with medical recommendations. Because sometimes people who've experienced adversity, it's a real challenge for them to take care of their own health. And for others in other fields, again, these techniques can be adapted to any field, any setting. The principles all remain the same. And so that's what I want to spend the rest of the time going through, is some examples of how we can do that. So I think I will maybe just take a quick pause to see, Sarah, if there's any questions before I move on.
Sure, I actually do have two right now.
Okay.
The first one is regarding some of the statistics from the ACEs study. And the question is, what is your interpretation of the significant difference in psychological emotional abuse in Wisconsin at 26% and the Kaiser study at just 11%?
Yeah, that is a good question. Let me go back to the slide that we're talking about so people can see what's being referenced. So you can see the Kaiser study, the psychological emotional abuse was at 11%. In Wisconsin, it was 26%. And then kind of conversely, Wisconsin's lower on the physical and sexual abuse percentages than the Kaiser study. So this has been brought up, a few times, and I'm not sure there's really consensus over to what the reason is behind that. This has been repeated a few different times for the Wisconsin data, and it pretty much is consistent in these reportings. One thing that I think has something to do with it is when they did the Wisconsin study, they didn't include emotional and physical neglect as questions, like they did in the Kaiser study. So you can see there on the bottom, there's only reports for Kaiser. So my take on it is I think some people who would have maybe reported emotional or physical neglect, had that been a question in the Wisconsin study, kind of just group that in over psychological and emotional abuse. I think the reason it wasn't included is it's kind of hard to piece out, I think, when you're retrospectively looking back, was that more of a neglect issue or an abuse issue? So they tried to encompass it all in one. For me, I think that's why that made the biggest difference, but I don't think that we have, any data or anything to back that up. That's just been my impression of how to interpret this as I've looked at it.
Okay, the second question is, how is resilience built if there is no traumatic experience?
So that's another good question. So there doesn't need to be, so every child needs resilience, and it doesn't need to be a ACE in order for something to be stressful for a child. So, starting as a baby, learning to walk, that can be stressful for a child, but having a parent there to help pick them up or to help them hold their hand so they know that if they fall, someone will be there. Thinking about a child their first time on a playground doing the monkey bars, that might be really scary for them or really stressful for them. And is there a caregiver there who's spotting them so they're not going to fall on their face, or are they going to have to face that alone? So children who don't have ACEs as adversity still face the adversity of childhood, normal, typical developmental challenges. And resiliency is built by having a stable person in their life or people in their life who they can feel that they depend on. So, in every child, there's an opportunity for resilience to be built by their caregivers, and also by those other people that they encounter. So their teachers in school, their daycare providers, if they're in any early education, anyone who really is involved in their life. So resilience is not just needed for kids with ACEs, it's needed for everyone for secure development.
All right, Dr. Hodges, a third question, more of a comment, has come up now, and this is back to the Kaiser study. Those in the Kaiser study were all insurance covered and therefore employed, primarily Caucasian, et cetera. In the Kaiser study, participant list was not a high-risk group due to the access to health care and employment, which is not representative of a larger population. And then my question is, how does Wisconsin's study compare to that?
That's a really good question, and it's a point I should have brought up. So the Kaiser study was a middle to upper middle class population, as mentioned, of people with insurance, private insurance. So it's actually thought that this the Kaiser study probably underrepresents the true prevalence of ACEs. And when this has been done in other populations, such as a more Medicaid population or done in more underserved areas, it's thought to be, or the numbers do get higher. In Wisconsin, they did, I think it was 13,000 people, and they tried to make it as diverse a population as possible. So it is not purely people with insurance. It's a wide breadth of income, socioeconomic statuses, and race, ethnicity, gender, things like that. So the Wisconsin study should be more representative of Wisconsin as a whole, whereas the Kaiser study is really pretty representative of Southern California upper middle class. So thank you for bringing that up, because I should have mentioned that.
And one final thing from the Child Abuse and Neglect Prevention Board, who sponsored the study in Wisconsin. They do have a link on their website with the full ACE reports there.
Oh, perfect. Okay.
Otherwise, that's it. We have it linked from the WeCan site, too, on the resources page, so you can check there, or the Prevention Board site.
Okay, perfect.
And that's all the questions for now.
Okay. All right, so let me get back to where I was, which I believe was here. Okay, So I wanted to just walk us through an example of a practice of trauma-informed care. And we're going to walk through the example of Kate. And again, this is coming from my healthcare lens, but this could be really adapted to any setting that any of you are working in. So let's look at Kate. So we know Kate as a baby had exposure to domestic violence in her home. Her parents ultimately divorced, and her mom struggled with some aorta alcohol or drug abuse issues as she was a young child and growing up. When Kate was school age, she got diagnosed with ADHD and anxiety. She struggled in school, had several detentions, and she spent a brief period of time in foster care. And now as a teen, Kate smokes cigarettes. You as her healthcare provider have talked to her about the health risks of this behavior, but despite that, her habit seems to be worsening. So understanding Kate's trauma history really helps to understand why she has chosen to smoke cigarettes and how that's an adaptive response for her past situations. So we know that nicotine can reduce symptoms of depression and anxiety, which Kate is likely suffering from. And so for teenagers or adults who have these symptoms, nicotine seems like a very helpful form of medication because it helps to reduce their symptoms. And so for someone in this situation, the benefits of nicotine may outweigh the health risks that they know are part of smoking cigarettes, but that just may not be enough for them to quit. So this is true also for other substances, so alcohol, marijuana, prescription medications, illicit drug use. These are used by people who are suffering some symptoms of anxiety, depression, PTSD as a result of their adversity to help them cope with that if they don't have any other coping mechanisms. So Kate's cigarette smoking is really an adaptive response to her past history. And we know, looking at some data and a lot of studies that have been done on this, is that these health risk behaviors are intimately tied to past adversity. So this is looking at ACEs and their correlation to early smoking initiation, if a person is a current smoker, and their development of COPD, chronic obstructive pulmonary disease. So you can see that the lightest bars are people with a report of 0 ACEs all the way up to the darkest bars for people who've reported 4 or more ACEs. And so for each of these, the percentage of people who have started smoking early, who are currently smoking and have COPD, it's higher for those with more ACEs. So knowing this and knowing this history, how can we take a trauma-informed approach to Kate? Because we know about her previous experiences. So would it be helpful to lecture Kate directly about the problems with smoking cigarettes, to lecture her on her risk for cancer and her risk for lung disease and her risk for COPD? Is that going to be an effective way to get the message home to her and to get her to change her behaviors? Probably not. What probably would be more helpful is to explore with her through counseling or through interactions why she feels the need to smoke a cigarette, what that's helping her deal with, and to explore her past trauma and her past experiences in order to come up with some other strategies to help her cope. That is probably long-term going to be more effective to help Kate to stop smoking than a more direct approach. And this starts with asking the right questions. So here are a few examples of things that you could ask, but the possibilities are really endless, but all of these trying to get at the reason behind your behavior. So for example, what type of feelings do you get from smoking? Are there other activities or experiences that can give you those same feelings? Or what types of things trigger your craving for a cigarette? Are there ways we can reduce those experiences in your day or come up with alternative approaches? Or what are some positive things in your life right now, and how can we apply those positives to help you quit smoking? So really, it's just reframing the discussion to from a direct approach of this is why smoking is bad to what can we do to help you choose a more positive adaptation than smoking when you're having these same feelings? And again, these techniques can be applied in any setting, so it's not just healthcare specific. And creating a trauma-informed approach takes more time because you really need to know the patient's story, and the only way you're going to know that is to ask. And in the healthcare field, we find that people are sometimes resistant to this because it's a lot quicker to list off the 3 reasons why smoking is bad for your health than to understand the reasons behind why a person is choosing to smoke and what the past history that might be tied to that behavior is. But the only way you're really going to know is if you ask those questions. And you're also going to be able to develop a more effective relationship with the patient or your client if you ask the questions and then remain mindful of their past adversities. And the strategy that we use and we teach here is to try to stop, reframe, and adjust your encounter. So I'm going to walk us through what that means. So first, during a frustrating encounter with a patient or where something's not going well, you first really just need to stop. And if there's a child who won't cooperate, who's acting out, who's tantruming, who's throwing things at you, don't jump right away to asking what is wrong with you, but instead reframe it and think about what has happened to you, what past experiences has made you need to react to this stressful situation in this way. And all of us, no matter where we're working at, have had difficult experiences with a patient or a client. So think about, a child who's not cooperating, or a teen who won't quit smoking, or someone who's very defensive or argumentative, someone who's late for appointments or doesn't show up when they said they would, or someone who's not following your advice. Those can all be frustrating experiences when we feel like we're trying to help somebody. But we need to stop and understand that those frustrating or unhealthy behaviors are probably coping mechanisms related to the person's life story. And you're not going to fix those frustrating behaviors unless you really get to the root of the problem and address what those coping mechanisms are for. And so in order to do this, you really need to create a collaborative and non-judgmental relationship with the child and the family so you can get at some of the root of those issues. Again, this is not something that can be done in a 5-minute encounter, a 5-minute appointment. This really takes time to get at the root of some of these issues, but that's really the most effective way to promote change. Once you've kind of stopped and grounded yourself, you have to reframe your attitude. So, for example, the patient who's always showing up late for your scheduled appointments, or who's not showing up and you feel like you're very frustrated because they're wasting your time. Well, how can we reframe that and think about it from a different viewpoint? So maybe that patient is working long hours or is on the verge of getting fired for missing too many days of work. Or maybe that person has a trauma history and it makes it difficult for them to time manage or to plan ahead in order to get to your appointment on time. So how can we help that person? So could we have more flexible hours so that they could come after work? Could we figure out some type of appointment reminder system, texting them to remind them about their appointment? Or could we do some assistance with transportation to help to get them to the appointment in a more timely manner? We need to really address the underlying issues in order to help that person with this time management. Another example, I'm sure we've all encountered a parent who you're working with and trying to help who's spanked or screamed at a child right in front of you in response to misbehavior. And our first reaction is, oh my gosh, I can't believe they're doing that right in front of me. What is wrong with that person? Why are they treating their child like that? Well, let's reframe that. Maybe this is how that parent was raised, and that's really their only knowledge of how to discipline a child. They're modeling what happened to them. They probably view this as a normal parenting technique, or maybe they feel like this is the only effective way that they can get through to their child. So Could we help the parent recognize that there's a cycle that's being perpetuated, and that this isn't the way that parenting has to happen? Could we introduce positive parenting techniques right in the moment, or refer them to some positive parenting classes or sessions, or give them some resources? Because that parent most likely is just doing what they feel is the most effective way to get through to their child, and they may not have the tools in their toolkit to do other parenting techniques. Another example, a teen who is always forgetting to take their ADHD medications, and maybe it's like, oh, I'm trying to help you, but you're not taking your medicine. You have to help yourself before I can help you. Well, maybe that kid is on their own. Maybe their parents are working long hours. There's no one there to remind them to take the meds. Maybe they're feeling stressed out that the family's having trouble paying for all this medication. So can you help that teenager be empowered to take control of their own health? Can you help set alarms on their phones or their watches, or set up a reminder system that would work for that child? Or if really the finances are an issue, could you help provide resources to help with the cost of medications? Again, these are thinking outside the box, and these are things that aren't necessarily a quick fix, but it's really important to help to get to the root of some of these issues. And then the last step being to adjust. So helping the patients, the children, and the families develop insight as to how their personal history is affecting some of their current day decision-making, relationships, their health. Oftentimes people don't tie the two together, so they don't even think that their drug addiction is related to their ongoing sexual abuse as a child, that they haven't made that connection. So helping them develop insight that this is their adaptation to cope with what trauma they've had in the past. Sometimes they need help to even bridge those two together. And also establishing open discussions with parents about how their personal ACE history may be affecting their present-day parenting of their parenting skills towards their own child, or how their personal history may be affecting their ability to provide good health care for their child. So again, in a non-judgmental way, just having that discussion with families and with children to make sure that it's all out in the open, and that it can be discussed, so that any issues can be addressed to promote the best possible health and outcomes for the children. This is just an example of a way to adjust a medical encounter. Again, this is going to be different for everyone, but some things we try to do in our clinic is just recognizing that before an exam, sometimes kids are really nervous. Healthcare, especially when they know they're being seen for a sensitive type exam, if there's been a concern of abuse. So trying to give the kid as much control as possible during the exam, so they don't feel a loss of control. This can also, like things like talking them through about what's going to happen before it happens, so they know what to anticipate, giving the kids as many choices as possible, so that again they feel like they have some control. For us during the exam, we do a lot of talking, what we're going to do, which body parts we're going to check, so they know what to expect, and also making sure they understand why this is important, why we really need to check them. After an exam, thanking them and acknowledging that that was really hard, but they did such a good job, and thanking them for their cooperation. And then also just thinking about long-term management plan, things that are going to have to go on. So if can you add extra time to appointment slots if you're going to have to talk about some sensitive issues? Also making sure that you feel like you don't have to solve, in quotes, a person's problems all in one visit, that this is like tackling eating an elephant. You need to do it like one small bite at a time. You're never going to be able to swallow this whole. So can you address small parts of the child or the adult's health, and do one thing at a time, and just see them back frequently, because managing chronic toxic stress is a long-term process. You're not going to be able to solve it all at once. Those are just some strategies, like I said, from the healthcare setting that can be applied more broadly. wrapping up here, I want to make sure everyone has or knows about this resource. This is a online educational module that is available to anyone. This was developed by some of the pediatric residents and myself here in Milwaukee at our Children's Hospital Pediatric Residency Program. And it's a really good primer on toxic stress and trauma-informed care for the pediatrician. For some of you who work in other counties, feel free to share this with providers in your area. It's a free link that anyone can access. I feel like overall the healthcare community is just starting to come around on ACEs and toxic stress and even learning about this. So this could be new information for providers in your area. It is really encouraging that this is now part of the required curriculum for new pediatricians and for those in our healthcare system. So the word is getting out, but it has been slow to move along in the healthcare system. So a plug for any of you who have pediatricians or other providers that you could share this with. It kind of walks them through some of the things we just talked about. So please feel free to share. So we are wrapping up on time here. So in conclusion, really, I encourage you to shift your perspective and show empathy. Be mindful of opportunities to help break the cycle of toxic stress. Talk to parents about why it's so important to use positive parent strategies. Look for and ask for feedback on your clinic or your work setting about how you could make improvements to be more trauma-informed. Talk about this with your coworkers, with others who are in the field of helping children and families, and why it's so important to be approaching these families with a trauma-informed approach. Look for new resources in your community. People are always asking me for resource lists and things like that, and it's so difficult because each community has their own unique list. So try to stay up to date on where you can send families who are struggling with food insecurity or with housing or transportation problems or advocacy within the schools, whatever it may be, so that when you identify some of these issues, you're also able to identify a resource that might be able to help them. And then really just ask the questions so you can discover that person's individual story and work to help them. And then also just a plug for taking care of yourself, because a lot of times people who are in helping professions, who are day in and day out working with people with a high ACE history and a lot of toxic stress, that can take a toll. So just making sure that you take care of yourself as a provider so that you can be around for the long term to help others as well. There's a few additional references that are included, and then give a few more minutes left for questions if there are any, Sarah.
Okay, so I have one comment just on the interviewing. It's a comment that says that motivational interviewing is a great technique to develop self-motivation for the changes you were describing in people who are dealing with the effects of ACEs.
Totally agree, and there's actually some excellent trainings that you can take on that through various organizations, and I've had a few, not formal trainings, but kind of lectures on the subject, and it seems to tie in very nicely with this work, and it's something I actually am looking into learning more about.
And then I just wanted to say that we will post the module that you mentioned just a couple slides back. We'll post it on the weekend website.
Okay.
We have a resources section at wichildabusenetwork.org, and underneath that is community resources. There's an entire section on trauma-informed care and adverse childhood experiences. It's got some information on fostering futures, which was mentioned. It's got the full ACE reports from the Child Abuse, Neglect, and Prevention Board. We'll put the module on there, and there are other things as well. And so that's available for you today. So other than that, I haven't got any more questions posted. So thanks, Dr. Hodges. That was a wonderful presentation. And we want to
Okay.
thank everybody for being with us today. You can log in now at ocpe.mcw.edu to complete your evaluation, and we look forward to having you join us next month when Dr. Petska will give a presentation on unusual presentations of child abuse. Okay, so everybody have a great day.
Okay, thanks everybody. Bye.
Bye-bye.